Very happy to be here, so to speak. I apologize I can't be here with you in person, and I hope to catch up with you later on this afternoon or during the dinner this evening for further discussion. You know the context very well. You know the context of the fact that Alzheimer's disease is a chronic disease, and with the rapidly aging population, even though the incidence may be declining, one can expect the number of people with Alzheimer's disease will grow significantly. Interestingly enough, I'm looking at the baby boomers in the audience, and one baby boomer in 5 will develop Alzheimer's disease in his or her lifetime. But perhaps a more striking reason is that we need to prepare for the advent of biomarkers for pre-symptomatic Alzheimer's disease and real disease-modifying medications. Hard to say when that will happen, but it could happen in 1 year, 2 years, 4 years, 10 years, but the healthcare system needs to be ready. So in 2007, the then Minister of Health, who's now the Prime Minister of Quebec, Philippe Couillard, asked me to set up and chair a task force to write the Quebec Alzheimer plan. You can see here the plan, the 7 priority actions that had 24 recommendations, very, very complete and comprehensive in its approach. And today I have a short time just to speak to you about the recommendation, the priority action on access to assessment and care. You can read this slide as well as I can, and I can see your heads nodding. We will quickly have consensus on the fact that there's an issue of access to assessment, of people who have memory problems, to integrated management. We know that memory clinics can't handle the volume nor assure the comprehensive continuity of care. Most of the memory clinics are in academic centers. Most have long waiting times, and they're not really adapted, as this slide suggests, for comprehensive continuity of care, particularly for older patients who have not only Alzheimer's disease but have the bad habit of having many other chronic diseases. And unfortunately, primary care up until now has generally not stepped up to the plate in its ability to deal with Alzheimer's disease and related disorders, as it has more readily, for example, with other chronic diseases like diabetes, for example. And so the objectives that we set ourselves, among others, for this particular issue was, number 1, rapid access to assessment and management, and second of all, and perhaps most importantly, personalized management and innovative access through a trusting relationship between the patient and family on the one hand and a credible clinician. So Quebec is a distinct society, and so is Canada, because contrary to Britain, or England rather, contrary to France, where the Alzheimer plans say as soon as you see somebody with a memory problem, you send them right away to specialty care. Some of the arguments that I've heard to support that were not really evidence-based. Things that I've heard were, if it was your mother, where would you like her to be assessed, in primary care or in specialty care? Or if you had a brain tumor, would you want to have it operated on by a neurosurgeon or a primary care physician? Not really solid health policy arguments. We have recommendations since 1989 saying it should happen in primary care. We all know that primary care is the first contact, has longitudinal knowledge and experience, and is best equipped to deal with older persons with multimorbidity. There'll never be enough specialists anyways interested and trained in Alzheimer's disease to be able to respond to the tremendous demand. And there is some literature, not necessarily great, but there's some literature that says specialty memory clinics may not be more effective than primary care in assessing and managing people with Alzheimer's disease. So the approach that we are proposing is collaborative care model based in the family medicine group, similar to the family health team in Ontario, a multidisciplinary setting where family physicians work with other healthcare professionals. And basically, the idea is that this clinical team, mainly the family physician and the nurse clinician, in partnership with the patient and caregiver, will be responsible for detection, assessment, diagnosis, management of the vast majority of patients with Alzheimer's disease and related disorders using specialized services like memory clinics, for example, for the complex cases. So the objective is to how can we then enable and empower the primary care clinical teams to do this. And so that is where we get into the implementation in Quebec of the Quebec Alzheimer Plan. There was a ministerial decision with budget that was established, and the priority was, as I said, primary care, enable and empower the primary care clinicians, mainly the physician and nurse team and the family medicine group, to detect, diagnose, treat, follow the vast majority of patients with Alzheimer's. A strategic ministerial team was set up for implementation. There was mobilization and consultation within the clinical milieu, and there was a quick study in primary care to see what was actually happening. And in fact, there were many milieus where who did not wait for the ministry to start to implement some of the recommendations of the Alzheimer Plan. The approach of the implementation was interesting in the sense that it was decided not to do implementation throughout the healthcare system, but to select a certain number of implementation projects with budgets based in 40 family medicine groups. So anchored in the family medicine group, but in partnership with specialty and community-based care. And the evaluation, which is as real time as we can, but the evaluation is what can we learn from these initial projects to improve what they're doing? Not to say it's a go or no go, but to improve what they're doing, but particularly to how can we learn from these initial implementation projects in order to better understand the essential elements for improving and scaling up. There was support for each of the sites with project managers supported by the university networks. An interdisciplinary proactive trajectory of care linked to guidelines was developed and distributed, and within a training strategy for the clinicians. This is, I have to have a slide in French, but this is an excerpt from the from this interdisciplinary pathway that we propose. And the nurse plays a very key role, as the nurse is playing a very key role in diabetes care. And by the way, 80% of patients with diabetes are managed in primary care, and the patients are never sent to, and those patients may never go to an endocrinologist. And the nurse will play a very key role, the nurse clinician with the physician, particularly around information gathering, like the long process of taking the history, doing the different cognitive tests and functional evaluations, sharing this information with the physician, who can then has less time and will spend time doing the exam, deciding on any investigation, and then on deciding also on use of imaging, and deciding on whether there should be a consultation request to, for example, a memory clinic. Once the decision, just to give you an example, once a diagnosis is made, presented to the patient and family, the nurse will then spend a lot of time with the patient and family, and explaining the disease, etc. And then we'll say, here's my card. If you have a question, call me. So that person becomes a bit like the nurse navigator or pivotal nurse, as we say in Quebec, in oncology, that you probably all know. Call me. And even if you don't call me, I'm going to call you in a couple of weeks to see how things are going. So proactive chronic disease management. And the nurse and the patient and family set up a schedule of either telephone conversations or face-to-face meetings, and where there is further assessment depending on the evolution, and the physician can come in at strategic moments. And so here you can look at, and I'm going to not read this slide, I'm going to ask you to look at it. It's very preliminary results. But what I'd like to do is actually tell you a story, which is an anecdote, and an anecdote is not evaluation. The story is the following. It's the story of a small city in a mining area far away from the big city centers, where there's one neurologist for all neurological problems in hospital and ambulatory. And this neurologist was being inundated by consultation requests from primary care physicians on mainly and very often routine evaluation of routine presentation of Alzheimer's disease. Very interesting enough, he said, since we've started the implementation of this project in that city with the family medicine group in that city, the number of consultations, to his delight, because he has lots of work and he's trying to be more targeted in what he does, the number of consultations has gone down significantly. But the ones he's getting are really very significant and very complex, and that's the ones he should be getting. That's an anecdote. It's not an evaluation. The other anecdote, and not a formal evaluation, which we're in the process of doing, is a ministry evaluation based on a survey of the various sites. And it's clear that there's the implementation of these projects has introduced a whole new dynamic in the capacity of primary care to assess and manage a patient with Alzheimer's, and to change the nature of the relationship with specialty services. So this has been also the basis for the development of the Canadian Team for Healthcare Services System Improvement in Dementia Care, which is part of the CCNA initiative that Howard Churko has certainly spoken to you about. We're going to be evaluating the initiatives in Quebec based on more a top-down approach. In Ontario, we're based more on a bottom-up approach with people developing initiatives in family health teams and different approaches that have been developed, including by Linda Lee, family medicine clinic, family memory clinics within the family health teams. So we're going to be evaluating these initiatives in these three provinces. We hope to produce rapid and relevant results for the stakeholders, and we hope also to mobilize and exchange with the key lessons and strategies with the other provinces, and this has already begun with links with Nova Scotia and Alberta, which are developing Alzheimer plans. So in conclusion, we see the development of a collaborative care model anchored in primary medical care, closely linked and supported by specialty care. It's really a paradigm for management of multiple chronic disease. If we do management of multiple chronic disease right, we'll get Alzheimer's disease right, and vice versa. The notion of these implementation projects with evaluation with the perspective of progressively scaling up. It's an excellent training ground for medical, nursing, social work, neuropsychology students, residents, and graduate students, and so hopefully the basis for an ongoing Canadian and international research and policy development through our Canadian Team for Healthcare Services and System Improvement and Dementia Care. Thanks to Pierre Bouchard in the ministry. You can see the links for getting these reports. If not, simply send me an email. Thank you very much.